Thank you, and I'm not that brilliant. She's just being nice. She talked me into coming here. So I've been doing this 25 years, in the medical field for 30. And my practice as an NP, how many NPs are in here? Okay. So my practice is a little bit My practice is a little bit diverse. I have my own thyroid biopsy clinic, so I have my own thyroid ultrasound machine. I do thyroid biopsies. I operate 1 day a week, and I also do like what I call my normal clinic stuff, post-ops, follow-ups, and all that stuff. So all of you should become nurse practitioners. I happen to know the director of the program at U of R happens to be Mrs. Chennel, not Todd Chennel, just in case. Like, just talk to you. So my specialty is endocrine surgery. I'm also endocrine trained. I also did bone marrow transplant, so I have a huge oncology background on top of endocrine background. And so this is a talk that I get phone calls from the ED primary care's office all the time about this. And so some of this I got is a little bit medication heavy, just so that you guys understand why the providers are ordering this medication and how critical the timing of this medication in the ED is to the patient. So learning objectives, describe the spectrum of the clinical features of the pathophysiology. I'm heavy into pathophysiology. Identify the factors to help make the diagnosis. Discriminating the emergencies, because myxedema and thyroid storm, although have similar features, they are critically different. And develop an approach for the rapid evaluation and start initial treatment on these patients. Eventually, you're going to call endocrinology for a consult to come down. But getting these critical steps will keep the patient alive, because these patients can decompensate and can drop pretty quickly. So this is a spectrum of thyroid disease. And so euthyroid, their normal thyroid, and then there's a myriad of diagnosis, subclinical, mild, moderate, severe thyroid storm, and then all the way down, which is hypothyroid, is actually what myxedema ends up being. And in the patient population, typically my Mennonites, Amish, economically challenged patients, because if they're on thyroid medicine, for whatever reason, say in my world, we take out their thyroid, we send them home on a prescription, a lot of these people, they'll take the 30 days that we give them, and then they won't renew it. And so it's not like they go 2 weeks without taking their thyroid medicine, and all of a sudden they're hypothyroid and they're going to show up in the ED. It takes months for this to happen. And the same thing with storm. Sometimes in storm, the patient, most of my patients that are hyperthyroid are on a medication, as you'll see, really already know the symptoms, because they should have been heavily counseled when they were started on some of these medications. Sometimes they're not, sometimes they're just like, okay, so I did some per diem time at the Monroe County Jail, and I had a patient that was on lithium, and he came in for drugs, and he was acting kind of all loopy, and they kept saying, well, he's just detoxing. And so when I came in, I sat with him, and he was on lithium. And nobody had ever done a lithium level. Nobody had given him his lithium. And so when they restarted him, they whacked him with a big dose, and that threw him in the thyroid storm. The kid could have died in the jail for something simple as he was on too much lithium and nobody checked his levels. It threw him in the storm. So we'll start with myxedema. So it's a life-threatening clinical syndrome and results from decompensation from severe hypothyroidism. It's at about 2.6 million cases a year. Mortality rate is around 7%. Historically, it used to be 30 to 50% if you had myxedema. You had a poor survival rate. As the years have evolved and people got more in tune to thyroid function studies, this has become less, obviously. Big risk factors: old age, lower socioeconomic status, winter months. It's greater in females than males. So hypothyroidism plus decompensation. So I have Hashimoto's disease. I get hypothyroid occasionally. I don't go into max edema. I could, but it's based on not just being hypothyroid, it's the clinical symptoms that go with it. So you don't need to go right to coma either. So people they always say, well, it's not max edema because they didn't go into a coma. That's not true. That means that they're on their way, right? So you get a gunshot wound and it's bleeding. They're not dying from the gunshot wound yet until you stop the bleeding. Unless you don't stop the bleeding, they're going to die, right? Same principle here. If you don't correct the thyroid issue, the patient will go into a coma and die. Hopefully, they're going to be taken care of long before then. So my favorite slide is, get a THC, please. That's all you have to do. One simple blood. If you're going to order $1 million panel of blood work on a patient, and I don't care if they come in from a broken foot, you should always get a thyroid function, my personal belief. And the reason I say that is half of the patients that show up in endocrine clinics are stuff that were found by accident. What I mean by that, so you see a patient, they got in a car accident, you pan scan them, you got some broken ribs, by the way, you got a thyroid nodule. It goes by the wayside because you're treating their broken ribs, right? And then all of a sudden, they go back to the primary, and then I get a phone call saying they found a thyroid nodule, no thyroid studies, and lo and behold, the patient, about 50% of my patients, will have either hyperthyroidism or hypothyroidism, undiagnosed. So, big things, tiredness. Everybody's gonna have thyroid disease, by the way, when you walk out of here, so I'll just give you my card now, so if you wanna call me. So, tiredness, weight gain, skin changes, dry skin, constipation. There's a myriad of symptoms. So I have Hashimoto's. I'm not fat and bald because of my Hashimoto's, but my puffy eyes are. That's one of the symptoms is eye issues. And so, but the hallmarks are they start getting decreased mental status. So as they're going along, and also hypothermia is a huge one. So they're cold, their temperature starts dropping. And one of the things that we talk about, it's not rapid heat. You can't throw an electric blanket on them or a bear hugger and crank up the heat and roast them like a potato. You'll kill them. It's blankets, and it's a slow warming process because you'll put them in a shock, right? So just think of somebody who's super hot, you don't give them an ice bath. Just like if they're super cold, you don't throw on all these bear huggers and stuff. So max edema, the number one cause is Hashimoto's or thyroiditis, they call it. There can be environmental iodine deficiency. So back in the day, we were iodine deficient in this country from the 1900s up until basically 1980s. And the reason is because we didn't have a lot of iodine in our diet. So if you go back in time and you start looking at the old game shows, you'll see people, or even the old shows, you'll see, because this is what I do for a living, stare at people's necks. And you'll see, oh my God, these people had goiters. Well, the reason they had goiters is that we had so much iodine deficiency, the thyroid likes to grow and increase its surface mass to get more iodine. And we learned this from our Asian colleagues because in Japan and Korea, they eat a lot of food that's high in iodine. And we found out that they still get thyroid nodules and thyroid disease, but their thyroids are much smaller than in the US. And that's why now, if you look, there's iodine in everything. Salt, milk, you look at anything, I guarantee you, it has some kind of iodine in it. And lo and behold, goiters, which is just an enlarged thyroid, have gone away for the most part. They've had radioactive iodine treatment for a thyroid cancer, or they've had thyroid surgery. So look at the neck. If there's an incision on their neck, they either had thyroid surgery, they had parathyroid surgery, they had something done to their neck, right? Drugs, big ones, amiodarone, lithium. They've had immune therapy for whatever reason. And then secondary, which is pretty uncommon, pituitary or hypothalamic masses. But I think that's getting a little beyond for what we do and for a rapid assessment in the emergency room. And so when is it not just severe hypothyroidism? So again, it's decompensation. You're going to be sick of hearing me say this word. When they start decompensating in the emergency room, something, badness is coming. End organ damage, altered mental status, kidney function. That's why you get, obviously in ED, you get a full panel of blood work. And again, that's why you should always do a TSH, because you see their kidney function going down and they don't have a history of it. There's a problem coming. Cardiovascular, they get hypotensive, they get malperfusion, they start going into shock, they can go into respiratory failure. And again, hypothermia increase the risk of mortality. Once they get cold and you can't get them warm, they're going to die. And the reaction is from a lot of people, get the bear hugger, get everything on them, get hot packs, load them up, make them 5,000 degrees, except you can't warm their core. You have to warm them slowly. And I don't mean putting a Foley in and running warm water or a rectal tube in. I mean, if I don't like you guys, I'll order it. But that's not what you want to do. So other ones that can cause it, infection, sepsis, trauma. Burns is a big one, patients that get severely burned. Surgery, we already covered that. Cardiovascular, hypothermia, out in the cold, shoveling the snow. The older crowd out there shoveling in their t-shirt because they got hot and they don't realize they're getting hypothermic. And then drugs. Opiates, just like my young man that was in the jail, it started with between his opioid use and his lithium really is what caused him to go in a storm. It probably was a combination of factors that threw that kid into storm. So, big one, especially around here, is wintertime. In the summertime, it's not that we don't see it as much, we do, but for most in upstate New York or most cold areas, it's usually the winter months when typically I get more phone calls about this. And again, rural populations, underserved areas are probably the three big ones. And so again, they start getting confused. They may come in confused. Somnolent, they comatose. So everything is on the downside is the short version. They get decreased reflexes. And so, again, this really is a good assessment, and we really rely between the nurses and the nurse practitioners because it's our assessment. I mean, when you come to me and say, hey, he's got no reflexes, his temperature is 34, doesn't know where they are anymore. They came in, they kind of were a little bit oriented, now they don't know what's going on. And so it's a progressive decline over hours. It's not, they could show up. But typically once they hit the ED, it's a progression. And so this is a big one because my daughter's psych, is some people think, well, it's just they have psych issues. So they're either acting out or they're depressed, they're not taking their med. So you get a lot of the homeless people, they're not on their psych meds. Okay, great. They're not on their psych meds, but that doesn't mean they don't have something else going on that's going to cause their decline. And so respiratory failure, hypoventilation, they get hypercapnic, get an obstruction. Thyroid can get engorged, hypo or hyperthyroidism, the thyroid can engorge. And where does the thyroid sit? Right on top of your trachea, right? So it's like stepping on a garden hose. A slow compression of their airway can happen. So some of it is over a period of time, months. I get a lot of patients, I was fine last year when I saw you, but now, my husband says that I snore and he has to push me and roll me over. She's not snoring per se, she's choking. She's laying flat, the thyroid is crushing her airway, so she snores or makes shorten of breath so that she gets pushed, turns on her side, and it decompresses her airway a little bit. So historically, respiratory failure has been a major cause of death, not really temperature, due to they go on a vent, right? So you're losing their airway, you're losing ventilation. The first thing we do is sedate and put them on a vent. So it becomes less of it if they make it in time. it becomes less of an issue. So decreased heart rate, again, the take-home message from max edema is everything starts slowing down. Gradually, you'll see this. Cardiac output, they'll start losing distal pulses. So you'll start noticing while their pressure's getting soft and you grab, I can't feel their pulse anymore. Still got a heart rate. And that's because everything's getting crushed. Decreased cardiac output, again, you're going to have, obviously they're going to be on a monitor, you're going to be checking their blood pressure, and you will see this slow decline. That is the trigger that if they're not getting better or at least being stable, then something else is going on. So this is the perfect setup for heart failure, especially in patients that come in with some underlying cardiac disease. This gets missed. Why? Because everybody thinks, well, they've got CHF. This is why they're having their cardiac issue, which is true. This is just adding gas to the fire. So some of all my changes, again, this is sort of a take-home slide of what's going to happen to them as they go. The big thing too, swollen tongue, the froggy voice. Why are they getting a froggy voice? There's two nerves that run behind the thyroid called the recurrent laryngeal nerves. So I have Hashimoto's. I can change my voice by just pushing on my thyroid. Eventually, if my thyroid keeps getting bigger, I'm going to have surgery, which I don't want because I do this for a living. However, I can't lose my voice, but that's one of the signs of thyroid disease, is that either you have a goiter that's pushing on the nerve, or you have nodules, or you just have plain thyroid disease. Cardiorespiratory we talked about, neurologic we talked about. So baseline thyroid functions. It is the cheapest, fastest way to get back. The reason why, as you see, they'll order thyroid antibodies and all that to make a diagnosis of like Hashimoto's or so forth. The problem is antibodies take days to come back. TSH, T4, T3, all that, you should get back an hour maybe or so. So you'll know pretty quickly. Primary team assessment, again, if they're starting to decompensate with what you're already doing to the patient, they're in trouble. And you can call Endocrine, but typically they're going to come down and make sure all this stuff is ordered. But these are the things that they routinely will want you to be ordered. A venous gas, an EKG, put them on get a troponins, put them on tele, and also adrenal insufficiency. Your head's going to have headaches when I'm done talking about all this. There's so much that goes into this. So now you're like, okay, Todd, we're on thyroid. Now you're talking about adrenal insufficiency. Because cortisol will cause that. If they don't have enough, right now, my adrenals are getting squeezed because I'm nervous, even though I talk every year. I'm getting squeezed right now. My cortisol level is probably off the chart because you're nervous. Same thing when you're sick. You're crushing that, which causes vascular collapse. So one of the things we do is check a cortisol level because they could be having ACTH blunting from the adrenals because they're squeezed so hard. And then what does that mean for you as providers or nurses, which we'll get into? They need steroids, rapidly steroids. And I don't mean hanging it in a bag and running it in over 5 minutes. I mean a syringe full as fast as you can slam it into them. So target, obviously, ABCs, treating the decompensation event, right? So their blood pressures are dropping, fluids, right? Fluids equal pressure, and restoring the hormone levels, which we'll get into. So have a low threshold for antibiotics because, again, infections can cause this. So sometimes a lot of the endocrine people will say, start antibiotics, even when you're like, well, I don't have cultures or anything. It's not going to hurt the patient, but they're already thinking if they have this problem, it could be caused by an infection other than thyroid disease, right? Respiratory support, we've talked about, cardiac support, hypothermia, we talked about temperature control, and warming too fast, right? We're going to crush the patient. So again, I'm not trying to sort of fly through this, but each one of these talks is about a 2-hour talk. So I'm not trying to overwhelm you, but to keep things rolling here. So big thing, levothyroxine is the big one. You can give it IV. It's 200 to 400 micros per kilogram, typically we do, or you can just, they'll say just give them 200 milligrams IV and just push it into them. It takes a little hot minute for this to work. So thyroid hormone takes a while to absorb and kick it off get bound to the receptor sites. And so it takes a little bit to that. You can give oral, which takes way longer for the absorption effect. And then, again, oral bioavailability is pretty low. It's only about 50% of the time. They'll absorb what you give them, about half of it. IV, they get, I think it's 90% bioavailability if you push it. And then you can, if you're thinking sepsis, because they can come in multifactorial, right? So they can be sick, they can have heart failure, they can be septic. So again, cultures, there's going to be a lot of stuff that if they're thinking this is what they're going to order, is pan culture the patient. If you pull this up in all your hospitals, I'm sure have records when you get into the pharmacy piece. When you're especially doing IV stuff, they'll do a loading dose. Oh, do you want to order a loading dose first? I would skip the loading dose and just slam them with some, you're not going to overdose them on levothyroxine. And then once they're stable, they'll convert them to oral. And the recommendation is to go low and go slow with thyroid. It's a hormone. So you're sending them home, and the reason why they say go low is so you don't want, if you make them too much hyperthyroid, the cardiac, which you'll find out in STORM, a big cardiac issue with too much thyroid medication. So you don't want to flip them the other way where they're profoundly hypothyroid and you slammed them with too much thyroid medicine over time. Now they're hyperthyroid. So it's a balance. That's why a lot of primary cares, a lot of phone calls I get are, well, the patient's TSH is 10. I want to start them at 100. No. 25, wait 6 weeks, and then you slowly make incremental adjustments to it. Because again, it's always go low and go slow once they're out of trouble. And so this is my lady who showed up like this, and lovely nails, by the way. And so she was homeless and was supposed to be on thyroid medication, and this was 2 years she hadn't had any thyroid medication. This is 3 months, hospital, rehabilitation, back on her thyroid medicine, a nice manicure, and we fixed her. But if somebody shows up like this, I mean, they're in problems, right? That's not, obviously, it's not normal. I don't look at everybody's feet like they do, like you guys do in ED, you do this whole thing. Me, I'm just like, right here, this is what God focused on. But she survived, and now we got her in a program to get her medication, and it's strong. We have a nice outpatient program for patients that are homeless or indigent, and to get them the medication they need. On top of the fact that she also was on a statin, and she was on metoprolol, and she was on a host of other meds that she hadn't taken either. So she really was a hot mess by the time she showed up. So we'll switch gears a little bit to thyroid storm. But I will tell you just a quick thing about one of my attendings, I work with an endocrine who sends me a lot of patients. He was giving this talk to the medical students, and they said, well, what if they don't have IV access and they can't take PO? You can give it rectally if you have a grudge against the patient. That was his thing, that you give it rectally. And I'm like, I think it's more of a grudge against the nurse, that you got to roll them over and start sticking levo up their butt is probably not ideal. But if you got to get it in them, that's one way to do it. Don't do it to me, by the way. I love all you guys. So if you see me in ED, no, we're not doing this to Todd. So Storm really is, the thyroid is on fire. It's on fire. It is literally on fire. And so Storm, again, it is more life-threatening than max edema because hyperthyroidism, because it affects the cardiovascular much more profoundly than hypothyroidism. Much higher mortality rate. All comers, 10 to 20% that show up with Storm in the ED are not going to make it. And some of it is timing, them getting into the hospital. My young man that was in the jail just was misdiagnosed. And so this happened, especially in the psych world. Lithium is probably one of the biggest offenders of thyroid storm that gets missed. Because the first inclination is you call psych. Psych says, oh, they're just taking too much lithium, we'll lower their dose. And then they don't get better. And then hours go by, and now you're almost too late because they've been in storm for so long and they're decompensating so fastly, they can't recover. Again, older age, greater in female than men. I have to say, women, you guys get the short end of the stick. Thyroid disease, pregnancy, somebody in your life like me or a wife. I'm just telling you, I feel bad for you guys. I'm just telling you. My wife who had thyroid cancer, she's a nurse practitioner as well. Perfectly healthy, I have little stories. Perfectly healthy little Italian girl. Diabetes, thyroid cancer I found, high cholesterol. She looks at me, you're fat. What's your problem? Nothing. I got some hypertension, a little thyroid disease. I get diabetes. You eat candy like it's free. So just saying that. It's a gene thing. So Graves is the #1 cause of thyroid storm. Toxic multinodular goiter. Painless or painful thyroiditis. So the most common ones of thyroiditis, pregnancy, postpartum thyroiditis is a big one. I use my niece. She lives in Vegas, had a baby. 8 months goes by, she calls Uncle Todd, I feel tired, I'm gaining weight, PCP. I go, just get a thyroid function, it could be this. Sure enough, her TSH was like 90, which I could not believe she was not in the emergency room. She just got postpartum thyroiditis. It's being treated. The thyroid doesn't have to be painful. It can, but I would say it's more painless than painful. Drugs, again, similar drugs, amiodarone, lithium, immunotherapy does not like the thyroid. Secondary TSH hormonal, meaning are they taking too much thyroid medicine? I had a patient that wanted to lose weight, was on thyroid medicine, so she was self-dosing her medication. So I was wondering why the pharmacy kept saying she's out of her, she keeps calling in for refills. Well, she was taking triple the amount of hormone. And when I checked her TSH, it was undetectable. Of course, she was also having palpitations all the time, and she was sweating all the time. And so the problem with that is we had to back her down slowly because you can't cold turkey them, right? Because you're going to throw them into cardiac arrest. But then the problem is she felt twice as bad for 6 months to a year because thyroid hormone affects every 6 weeks. So she felt bad to begin with, and she only made the situation worse. So now there's nothing to be done. You're going to feel crappy, but you're not going to die. So there's 2 scales, the Birch-Westcott scale and the Japanese Thyroid Association. Probably this is more once they've been in the ED and they've been treated, they'll use these scoring paths. This is not something that when I got called to the ED for it, I don't whip this out of my pocket and go, okay, let's see what their thermal regulation, I don't score. I mean, we treat the patient and get them stable first, and then usually endocrine will come in and they'll use one of these grading scales so that they'll assess what to make the diagnosis and what the treatment algorithm actually, because if these are poor, that's what they base the treatment algorithm on is as they recover. So they'll do this multiple times through their hospitalization. They'll keep scoring the patient. So when is it not just hyperthyroidism? Decompensation. I can't say that enough, as you've heard. End organ damage. Same thing as max edema. Mental status changes. The kidneys take a hit. It's the opposite temperature, right? They're hyper, right? Again, you can't load them up with ice packs and freeze them out. You'll kill them. Tachycardia, they go into hypotensive shock, and they'll go into respiratory failure. And so, again, infection is a big one. That's why they'll order antibiotics. A lot of times, endocrine will just say, even if you've pan-cultured them, there's no cultures back, they may just start them on an antibiotic. That's why. Cover trauma, burns, surgery. Obviously, if you see an incision on their neck and they tell you, yeah, I had thyroid surgery, you see they're on levothyroxine, and ask them, how do you take it? 2 reasons. Thyroid medicine, 1, has to be taken on an empty stomach. If you take it with food, you might as well not even be taking it because it won't absorb, right? Or, like my other patient, oh, I wanted to lose weight, so I'm taking double. I take 2 of my thyroid pills every day. And so that's why if you see him on thyroid medication, it seems like a simple question. Well, how do you take it? Or how often do you take it? Cardiac, obviously, we talked about heat exposure. Summertime's coming, our runners, our athletes. This is why a lot of the paramedics, they'll put the ice packs in their armpits and in their groin to trying to get their temperature down, which is the right thing to do. And then they're pushing fluids as well. You don't want to give super cold fluids, but they will chill the fluid a little bit. Because again, it's a fine line between throwing them into cardiac shock and trying to prevent vascular collapse. Childbirth, again, sorry women. Blood clots are a big one, and then drugs. So our patients that come in that have found down or just came in with a drug problem, this can happen, and then autonomous nodules. So eventually, what you'll see is once they endocrine or they start treating them, they'll always order an ultrasound of the neck. And the reason they're doing that is twofold. 1, you can have Graves' disease, obviously, which is the whole thyroid is hyperthyroid. You can have toxic nodules, meaning there's a nodule in the thyroid that's autonomously producing thyroid hormone. It's called Plummer's disease. And so that will not respond to some of the medication we're going to talk about. Plummer's disease is a surgery. There's no other way to treat it. The patient's going to get a surgery. Or they just want to make sure they don't have any other thyroid nodules. Maybe it's not an autonomous nodule, but they could have a thyroid cancer that is undiagnosed. Thyroid cancer is pretty uncommon, but again, it's a lot of times in my world, it's found by accident. Hate to bore you with stories. My wife got pneumonia, gets a CT of her chest, meet the Dr. Paskalakis, who's our chief medical officer now, but he was a pulmonologist, and we're looking at the scan, and I'm like, geez, I go, Maria's got some thyroid nodules. We see them all the time. Nothing to worry about. Todd, because I do this for a living, I had obsessive compulsive disorder. I ordered an ultrasound, or Dr. Muam did, because she's my wife. And as soon as we saw the ultrasound, I knew she had thyroid cancer. It was very crystal clear the way the nodules looked. And so this is what happens quite frequently. They get pan scanned, they see a nodule, and some people will poo-poo them and just say, it's nothing to worry about. Or their primary care is very in tune and goes, well, we should get a formal ultrasound because that's what the radiologist will recommend. But that's not like emergent, like, oh my God, they have to have an ultrasound at the bedside. Now, a lot of people, residents and NPs are starting to carry the butterfly. If you guys know what that is, the butterfly ultrasound probe. So they can use their phone or a tablet. So a lot of times they'll do a fast exam They can do this a fast exam with these butterfly probes. I have one, even though I have my own ultrasound machine, but they're great for bedside quick ultrasound, especially of the neck. So marked increase of thermogenesis, which we talked about, hypermetabolism we talked about, and increased end organ activity. So heart rate we've talked a lot about, tachycardia, sort of beat that into the ground a little bit. Increase in cardiac output, or decrease resistance, and then systolic hypertension. Perfect setup for ischemia, obviously, as you guys know, if their peripheral resistance has gone down for too long, their limbs are going to start deperfusing, and now you've got vascular surgery coming in to help out. So again, similar to maxedema, they're very similar, confused, they're disoriented, they'll have poor or no response to stimuli, so they'll kind of check out and you'll give them a sternal rub or you'll pinch their tricep and they will just sit there and stare at you and have no reaction. Again, or on the psych end, it's the opposite. They're more agitated, they're more, just sort of, almost looks like they're having a manic moment. And it may be part of the problem, or this is contributing to it. So now it's multifactorial. So you're treating their mental illness and you're treating the medical side with the thyroid. And so after we sum all this up, basically, just like slide is just like the one for maxedema, except they're more warm, they're flushed. This is a big one, a Van Gaff sign. The upper eyelid lags behind, so they look down and their eyelids still slowly will start to droop, or they look up and the eyelids almost like they don't move and they won't blink. So if you sit there and talk to the patient and you're staring at them and they just stare back and you blink, you all just blinked at me, they'll just sit there and give you a deadpan stare. And it's not because particularly it's psych, it's just that the muscles that control the eyelids aren't functioning correctly. So again, just like maxedema, order thyroid function studies. That's all you have. That is like the basic thing to do is they come in, order a thyroid panel. We'll take it out of the picture, so this is off your plate of diagnosis, or it's going to help confirm the diagnosis. This is actually a patient of mine who showed up for a thyroid biopsy, and their TSH was undetectable, which you can't do a biopsy on because you'll throw them in the thyroid storm when you poke a thyroid with a needle. And so when I put it on Doppler, that's not normal. That is so hypervascular, all that. So I would say this spot here is what the whole thyroid should look like. It should just look kind of like this, nice and smooth, no flow really through it. But when they're hyperthyroid, this is what it looks like. And actually, that's the IJ. That's the carotid artery. The carotid artery should not look like the thyroid. Or the thyroid should not look like the carotid artery, I should say. This is trachea. So you can see, this is a big thyroid, and this is why they get crushed. This is why they start having trouble swallowing, or they'll say they choke on their food every now and then. It's just because the thyroid gets so engorged, it's just like stepping on a garden hose. Unlike hypothyroidism, you have to be pretty quick for thyroid storm because, again, the mortality rate is so high because it takes a while for people to get in tuned and start doing blood work. That's why always get a thyroid panel. You can also take a feel of their neck. The other thing you do, which you will appreciate, put your stethoscope on the thyroid. Why are you going to do that, Todd? Because if they're hyperthyroid, you'll hear a bruit. You put the stethoscope on their neck and you hear a bruit, that's a 911 to an attending. I think they're in storm. I listen to the thyroid. I hear a bruit in the thyroid because you're not supposed to hear that in the thyroid. That is one of the rapid things that I teach my MP students. If you think somebody's got a thyroid problem or storm, just put a stethoscope. And when I see patients for a pre-op, I always have my students go into the patient's room And part of their exam is to put the stethoscope on the thyroid and listen to that. And again, mental status change, they decompensate really fast. But you're going to get blood work, right? They're going to order just a basic panel of blood work. But again, getting a thyroid function panel, I cannot stress that enough. And then, of course, we already talked enough about infections to get them pan cultured. And so supportive care, treating it, low threshold again, they'll start them on antibiotics just to make sure that they're not missing an infection in the short term. Cardiovascular IV fluids, typically, though a lot of times we have an ED, one of my mentors, who would, if they came in, he was so worried about that, he would put 2 IV bags on the pump or on a bag like we use in the OR, and he would put in 2 liters of fluid in about 30 minutes. And I wouldn't recommend that. But he was so worried about they were going down the tubes and they were vascular collapsing that he wanted to rapidly infuse them. And the other thing too is steroids. He would put hydrocortisone into the bags, each bag, and give them like 200 of hydrocortisone, which is a huge whopping dose. I wouldn't recommend that. He can do whatever he wants. It's his license. However, a liter of fluid, run it in pretty quick, give them 100 of hydrocortisone. They should respond pretty quickly. And then, again, check their cortisol levels to make sure they're not in adrenal insufficiency as well. Also, they can go hypoglycemic. So a lot of times, prick their finger, check their sugars, do it in the regular blood work. But don't be surprised to have some D10 around. So now getting into a little medication part of this is beta blocker. Propranolol probably is the number one thing, our number one beta blocker that we put patients on, whether they're in the ED or outpatient or if ICU, and you have Plummer's disease or Graves' disease or even thyroiditis and your TSH and your tachycardic. We like to put them on propranolol. And then obviously in the ICU, they'll give esmolol. I mean, they're dying. If they're out of the ED and they're going to the ICU and they start putting them on esmolol or ECMO, that's no good. And this, again, it's so complicated, this process we do, because what if the patient has already congestive heart failure or they're stage 4 kidney disease? They've already got reasons that you can't fluid overload them, except you have to fluid overload them so they don't go into it's a double-edged sword when you're dealing with these patients. So one of our famous doctors said being on a beta blocker is not the same as being blocked. Beta block, just because you give a dose of beta blocker does not mean that they're blocked. It's a cumulative effect. So yes, it'll help with the rhythm, but it takes time for that beta blocker to sort of kick in. And then they'll go on oral eventually, not in the ED, but eventually when they move the ED, they go to the floor, they'll start converting them to all oral stuff. And so things that will improve on a beta blocker, obviously, why we're giving it, tachycardia, arrhythmias, cardiac output, their skin temperature will start to recover a little bit. Muscle strength, dyspnea, behavioral change a little bit with propranolol, but we're trying to keep them alive, right? Things that typically won't improve is their core temperature. The skin temperature will start to warm, but their core temperature will not start to cool. So again, being beta blocked is different than taking a beta blocker. That's what he was referring to, that yes, they will start to see improvement, but that doesn't mean that they're fixed. Goiter size, again, in Graves' disease, all the stuff, the thyroid will get enlarged. Sometimes you can see it. You get a big guy or woman who's got a big neck, it's impossible. You get somebody that's pretty thin and this thing's thick, or a lot of times what I do is just have them lay there and swallow. And if you can see, typically you shouldn't see the thyroid move. So if they tilt their head back and they take a little water and they swallow and you see this thing move up and down, that's a good sign of a goiter, especially in people that have kind of the thick necks. So the antithyroid medications will inhibit new thyroid production. And so what we give them are the two antithyroid hormone medications. One is PTU and one is methimazole. Methimazole is only oral. There are some conversions to IV, but most pharmacies won't do it. You can give it rectally. You'll be very angry if we order that rectally. So we always order PTU. And PTU, the good thing about PTU is it's IV, can be converted to oral. What if the patient's pregnant? Methimazole will kill the baby. PTU will not, in theory, is what they say. So if the patient comes in and they're pregnant, they can't have methimazole. Or if they're trying to get pregnant, they have to come off methimazole and be switched to PTU. One of the big causes of miscarriages is thyroid disease. Another true story for me. You'll get sick of hearing them. I had 3 nurse practitioners at work in another division. All are having trouble getting pregnant. So in my tiny little brain, I'm like, geez, did they ever check your thyroid function? Nope. Went to their doctors. A month later, they all come, oh my God, my TSH is 6, blah, blah, blah. Started on thyroid medicine. I have 6 children now running around. They all got pregnant within 6 months of getting their thyroid function corrected. And so, but again, PTU is the fastest way to give it. IV in the ED can be switched to oral. If they're outpatient for whatever reason or you get them treated, methimazole is typically in the outpatient setting what they start everybody on. It's a provider in the outpatient world. I always start my patients on methimazole because it's outpatient. It's just what I use. It's not that I don't order PTU, but you get in a habit as a provider, as a nurse, you do the same thing with every patient, right? So this is me. I do the same thing for every patient. Why? I don't want to miss something because, oh, I'm going to try something new today. That's not how I practice, because I don't want to kill somebody. So iodine-induced Wolff-Chakoff syndrome, which I think Teresa's going to do a little talk on. So Lugol's solution is pure iodine. And you can give that because it will shock the thyroid. It decreases the vascularity of the thyroid. We typically will put Lugol solution or SSKI. We'll give that like 5 days before surgery. And what it does is it helps kick things off the receptor sites, but it also decreases the vascularity of the thyroid. The problem with this is it tastes horrible. And patients will, Dr. Muallim, I love the guy. Oh, just put a Tic Tac in your mouth and squirt the drops in, it'll be fine. Well, a patient made him put a Tic Tac in his mouth and put the drops in his mouth, and he threw up. Then it was like, hey, maybe we should mix that in orange juice or something. Like, hey, great idea. So, but some patients can't tolerate it. It upsets their stomach. So I'll get patients, oh, I tried taking it with orange juice or cranberry juice or something. It upsets my stomach. It doesn't mean we're not going to do surgery, but it just isn't, we can't do it, right? So this is something really in the emergent situation, probably not going to do this because technically it can be compounded IV, but just give PTU. Why would you don't need to give. This is more, for us, this is more of like a surgical world. And it also doesn't work if they have plumber's disease. And the reason why is if you have an autonomous nodule, say this is a nodule, this is thyroid tissue, PTU, methimazole, Lugol's affects the parenchyma of the thyroid tissue. It doesn't penetrate to the nodule. So patients that have plumber's disease, they'll say, oh, just put them on PTU or methimazole, the primary cares will, and it doesn't work because it doesn't penetrate the thyroid or affect the nodule. And so if you're thinking storm, beta blocker, PTU, fluids, steroids. This is kind of the outline that most providers in their head or they have in their little book that they'll follow. Is I guarantee you this is on their little chart when they open up their little book to figure out what to do. I guarantee you this is a slide because it's the same stuff we give our medical students. Oddly enough, you can use lithium. We typically don't because you don't want to have the opposite problem. And so for max edema, thyroid storm, it's very simple. ABCs, treat the decompensating event, restore thyroid levels to somewhere in the normal range. It may never be in the ED or immediately be that perfect, but if you can make them better, that will stop that decompensation from happening. And that's it. Sorry I flew through that, but